This next session features a wonderful regular participant here at the Medical Ethics Conference. Dr. Annique Hogan is a pediatrician at the Children's Hospital of Philadelphia, and she's also an assistant professor of clinical pediatrics in the Perelman School of Medicine at the University of Pennsylvania. She received her medical training at the University of Toledo Medical Center, and her areas of expertise including care coordination for children with complex medical needs. Today, Dr. Hogan will be speaking on trust in the pediatric patient-doctor relationship, case studies in complex care pediatrics. Please welcome Dr. Hogan.
Thank you so much for the privilege and the humbling privilege it is to speak at this conference and before this group of people, where I feel that I have really grown up as a physician as I started coming to this conference as a medical student and throughout my residency and then into my years of practice thus far, which I hope to be very many. So I don't have any conflicts of interest. I hope to achieve some someday. If it can be genetic, that would be wonderful. So I want to talk about trust in the patient-doctor relationship, and specifically in the pediatric patient-doctor relationship, because that is the world in which I live. So among the most rewarding aspects of my work in pediatrics are the relationships that I've been able to develop with my patients and their families. In pediatrics, when one speaks of the patient-doctor relationship, the patient and the family are nearly inseparable. The great majority of the time, while the child is my patient, my partners in caring for this child are the parents or the family. We refer to this as our patient-family-doctor triad. And while it is not unique to pediatrics, our field is unique in that this is the predominant relationship that exists in our practice. Very often, even at the start, especially at the start of our relationship, our patient, that is the child, is nonverbal and unable to communicate for herself. Now, most often this will change over time as the child grows and becomes a more active participant in her health care. However, and this is especially true in complex care pediatrics, this is not always the case. Our patient, the child, may never develop the ability to communicate for herself. So much has been written about the patient-doctor relationship. Each of our roles and responsibilities in this relationship, the impact that this relationship has on the care that our patients receive, and the impact of this relationship on us as physicians. Now, in looking back on my training in medical school and in residency, I was fortunate to have been taught and mentored by physicians who valued this relationship. And through the years I've attended this conference, I've developed a deeper understanding of my responsibility as a physician and what I must bring to this relationship. I have been afforded the opportunity here to reflect upon the impact these relationships have had on me and on my practice of medicine. I particularly like this quote from Dr. Osler in saying that we should strive to care more for the individual patient than for the special features of the disease, to put ourselves in his place, the kind word, the cheerful greeting, the sympathetic look. These the patient understands. So in thinking from the patient perspective, I recently came across a review that had been done by Matthew Ridd and his colleagues in which they assembled and synthesized the available literature regarding the patient and family perspective of this patient-doctor relationship. I was particularly intrigued by that because to this point, so much of what I had learned and had been taught to understand about this relationship, I realized was really quite one-sided. It was from the perspective of other physicians. And my patients have taught me so much over the years, but I just found it really enlightening to find a review that spoke about this relationship outside of the physician perspective. So in this review, their expressed aim was to derive a conceptual framework of the factors that define the patient-doctor relationship from the perspective of the patient. So they described not only the means by which the relationship develops, but also the factors that impact the depth and the strength of the relationship. So patients describe the development of this relationship with their doctor through the synergistic impact of longitudinal care and the experience they have with the doctor at each consultation or meeting. So longitudinal care, so that is the ability to see the same doctor at repeated visits. It is essential for the development of the relationship, allowing both the doctor and the patient the opportunity to learn more about each other and develop a common experience. So patients describe this ability to see the same doctor on repeated visits as an essential feature in the development of the relationship. It is notable that the regularity of visits, rather than simply the frequency, was of greater importance. So this tells us that it doesn't necessarily have to be a relationship that develops on over the course of many, many years, although that certainly carries a great deal of weight. But regularly being able to consult and meet with the same provider to discuss a particular problem or particular area or your health in general has great value to patients. However, this continuity alone is not enough. So you can have great continuity with the same provider who is always available to you and really not have a terrific consultation experience. So, what is described as the consultation experience is then equally important. This encompasses the interactions that we have with each other. Our patients are looking to us with certain expectations. They would like for us, I think this is not too much to ask, to be interested in them and in their story, to listen to them, to explain our perspectives and our plans in a way that they can understand, in a way that is clear, to be open to discussion and to their perspective, to really try to understand what their values are, what it is they are trying to achieve. We refer to this sometimes as their goals in their healthcare. And to involve them in decision-making if that is what is desired. And that's a very important if, and we know that, right? So different patients may be coming to us with different expectations from the perspective of shared decision-making. This has been pretty well documented, and I particularly enjoy the conversations around the complex dynamics of shared decision-making. Now, not all patients are able to communicate their story or their concerns as clearly as we would like, but from the patient perspective, and I find this also very interesting, it is viewed as our responsibility as the physicians to facilitate this discussion. They don't see it as their responsibility to articulate themselves perfectly and clearly, but ours to use our expertise to bring about a fruitful conversation. Now, one of the factors that impacts this experience so greatly is time. So our patients value the time that they spend with us, and they want to feel heard without being hurried. This remains a tremendous challenge, as we've talked about already so far in this conference, given the multiple demands on physicians, on our time, on our productivity, and for us to show what we are doing with this time that we are spending with these patients. So through longitudinal care and through the consultation experiences, this review describes that the depth of the relationship is able to develop. So they describe 4 elements of this relationship. So you have knowledge, loyalty, regard, and trust. So I would like to discuss each of these individually, but I will hold trust for the end because I want to and I hope to communicate to you how this component underlies each of the other 3. So I'll begin with knowledge. Patients want to feel that they know their doctor and that their doctor knows them. This begins with familiarity, but builds into a deeper knowing of the patients and a deeper knowing of the doctor, and being able to anticipate how the doctor will react to the things that they will say and that they do. I found this component particularly striking as I reflected upon my own practice. In my work as a complex care pediatrician, I do a great deal of what we refer to as medical quarterbacking. My patients have numerous specialists involved in their care, typically at least 3, but often upwards of 5 and 6, and several have 10, 12, 14 specialists. It is my job to get to know them, to synthesize their medical issues into a comprehensive summary and plan, and to develop an understanding of the patient and their family. My families want me to know how much their child means to them, what they are worried about, what they fear, how much they understand, and how much they don't. I take this responsibility seriously, And I invest a great deal of time and effort into this aspect of my care of patients. What I think I don't fully appreciate, I don't think I fully appreciated before, however, was how much my patients value being able to anticipate my reactions to the things that they say or do. So a couple of years ago, one of my patients, for whom I'd been already caring for a few years, was admitted for treatment of urosepsis. So for the non-physicians in the room, this is an infection of the urinary tract that becomes quite systemic and requires IV antibiotics in her case. So she's one of my most complex patients, and she fits into this category of having upwards of 10 to 12 specialists that are actively involved in her care at any given time. So among her many issues, she had a history of urinary tract infections, and she had developed renal abscesses previously, for which she had been receiving a prolonged course of outpatient antibiotics. Now, when I met her in the hospital, which is my practice to do, after a bit of hesitation, her mother finally disclosed to me that she had stopped giving the antibiotics at home prior to this admission about the week prior because she'd become concerned when she read the package insert that had detailed all the side effects of this particular antibiotic. She was concerned that the medication would make so many of her daughter's other medical problems worse. And now, of course, she was feeling terribly about the impact that this had had on her daughter. I could see how hard it was for her to share this revelation with me. It was almost as though I was watching her take a leap of faith as she tested the strength of our relationship and the trust that we had in each other. I recall the feeling of appreciation that I had in that moment, that she felt safe and she trusted me enough to share this with me. She was afraid of the reaction of the medical team, but she trusted our relationship enough to take that risk. I think she also trusted enough in my ability to advocate on her behalf to the rest of the team as well. I was able to thank her for her honesty and her disclosure, but then because we were now together on the same page, I was able to address her concerns about this medication so we could move forward in caring for her daughter. This had real implications on the care that we delivered to her daughter at that moment and the choices we made. So the next element bringing depth in a relationship is loyalty. So patients and families describe this as an agreement of sorts between the patient and the doctor. This becomes especially important for more chronic or long-term issues. For those patients with a high degree of medical complexity, the prospect of repeating their history multiple times to a new and unfamiliar person is really quite daunting. If they know a particular physician, if they can trust the physician knows them, or in my patient's case, knows their child, if they've developed an understanding of what to expect from that physician, and have experienced within these encounters a sense that the physician is listening to them, is respecting their perspective, and understands the role that that patient or family member wants to play in that relationship, then a degree of loyalty to that physician is felt by the patient and family. Now, this loyalty can pay dividends. So, for example, it can generate a higher tolerance of certain inconveniences that a patient or family may experience, such as time spent waiting to be seen, or the distance that must be traveled in order to see a particular physician. You know, I have a colleague that I work with who is just really an extraordinary physician, and her patients routinely wait about an hour to an hour and a half to be seen. And I have to say, for any of the patients that are hers, aside from the ones that she's just covering for a sick visit, I've never seen one of her patients complain. They bring extra entertainment for the children, they bring something to knit, they bring something to do, because they know that once they get into that room with her, she has their undivided attention. I mean, they have, her undivided attention. That degree of loyalty and the degree to which it can raise this tolerance level is dependent upon many factors, certainly, not the least of which is the nature of the problem and the nature of the patient and family involved in that relationship. But the more complex the problem, the more important continuity becomes. And for certain families, that loyalty has priceless value. But patients expect this loyalty on the part of their physicians as well. They want this to be bidirectional. This can be expressed in many ways, but this may include physicians having a sense of ownership of a patient and the problems they are managing, as well as a willingness to commit to following a patient through the complex workings of our healthcare system. One of the great concerns that my patients often bring to me is their experience in feeling that they have no one captaining their ship. Their children are so complex, and they worry that each individual physician is only looking at one little part and not at the whole. And that some people who try to look at the whole are so overwhelmed by this, they just take a step back and sometimes give up. They worry about whether and how they will be able to reach the doctor after that visit, or if they are in the hospital. They worry about potentially getting conflicting advice from the on-call team. Our families experience the pitfalls of the medical system and the care that is so often siloed, and communication between silos is really quite challenging. Our patients want and expect that we will talk to each other, to devise plans that meet their multifactorial needs, rather than asking our patients to ask your insertologist here what he or she thinks about that the next time you see them, and get back to me, let me know. Our patients and families want to know and want to feel that we are as loyal to them as they are to us. So the next element of this relationship is regard. The patients and families in these studies describe this as not only a sense of comfort in liking the physician, but also the perception that they are liked and respected by their physician. Patients and families come away from their experiences with us with a sense of whether or not they feel as though we are interested in them, if we are on their side, if they matter to us, whether or not we care about them and respect them. And I think it's important for us as physicians to realize and understand that we are responsible for the impression that they have. Our actions, our communication style, the words we choose, all contribute to this perception. And this sense of regard can either contribute to or detract from the trust that we have as part of that relationship. So this brings me to the discussion of trust. Trust may begin at a generic level, in trust in doctors in general, but then becomes refined over time into personal trust in an individual physician or a team of providers. It is important to know that different patient groups may be starting from very different places in terms of the level of trust or mistrust that they have in doctors in general or in the healthcare system. And there's very good historical and cultural background to explain that trust or mistrust. And even if we did not contribute to it, we have to acknowledge our role in understanding it and knowing what we are going to do about it in that particular individual patient encounter. Knowing this can help to inform us as the physicians about the task we face in earning our patient and their family's trust. Our patients and families want to be able to trust us with their problems and their vulnerabilities. The development of this trust is based in part on their impression of our openness, our honesty, and our recognition of our own limits. Do we know when we've gone beyond our realm of expertise? Do we know when to refer? Are we going to be comfortable and honest enough to say, I don't know what is happening here, but I will work with you to find out. I am not the expert in this, but I'm not going to say, I'm done. I'm going to help you to find the expertise that you need, because I'm going to work with you. I'm going to walk with you on this journey. It is affected by their knowledge of us through the continuity of the relationship. It can be strengthened by their loyalty to us and their perception of our loyalty to them. It can be strengthened by their regard for us and their perception of our regard for them. It can also be weakened or eroded by these factors as well. Trust underlies all aspects of our relationship. This trust must be bidirectional, though. There is the trust that the patients and families have in us as providers, and also the trust that we have in patients and families. In regard to the latter, it matters not only how much we actually trust our patients and families, but also their perception of that trust. Patients and families want to feel that they are believed. Our words, our actions, our body language can convey this impression. They feel mistrusted if their symptoms are not taken seriously, or if they perceive that we do not take their symptoms seriously, whether we actually do or not. Our patients' families need to feel that they can trust in the guidance we offer, that this guidance is based on a complete understanding of the problem, and that it's been offered with their best interest in mind. If we are not able to trust our patients and their families, our relationship is that much weaker and less able to meet our mutual needs in this partnership. Because while we are a partner in this relationship, it is an unequal partnership. We bear the greater privilege, and as a result, the greater responsibility and burden within the relationship. And it's important that we know that at the outset. So with these cases that I have chosen for today, I hope that it will become evident that among the many issues that are raised by each of these cases, there is a common thread. Each highlights a different example of a challenge to the trust that is a crucial component to the patient and doctor relationship. So in case one, if you refer to your packet, I presented the case of two brothers with ALD, adrenoleukodystrophy. This disease is devastating and fatal. This little boy presented initially as a really quite healthy young man who was only having some minor symptoms in terms of how he was performing in school and a few vision changes. In the course of one summer, he lost all gross motor skills, the ability to care for himself, the ability to speak, the ability to eat safely on his own. He became completely dependent upon others for his care. And in the course of this, because this is an X-linked condition, his brother was also tested, who was not having symptoms at that time, and he was found to also have this condition. And since he was pre-symptomatic, he was eligible for treatment with bone marrow transplantation, which is the only available treatment in this country right now. Elsewhere, gene therapy is an option, but that is in Europe at this moment. Now, it's important to know that in the period of time that it took for the brother to be able to progress from evaluation for BMT to actually getting his BMT, he began to develop some very, very mild symptoms. But he underwent his BMT and he was actually doing really quite well. He had some limitations, but his prognosis was much better. He was still able to communicate, although he was quite dysarthric. He was able to eat, although he could only handle certain purees and textures. But his prognosis was better. And this patient was going to get worse. But it was going to take quite a bit of time. It would be, we know from the natural history of this disease, it's going to take years before he progresses into a persistent vegetative state, and eventually he will die from this disease. It is important to know at this time, though, he is not in a persistent vegetative state. I provided for you in your packet the AAP statement on foregoing nutrition and hydration because, as I mentioned in the case, this was a request of this family. When we asked the family about that, we did learn that this patient's mother had a history of being a nurse's aide in an inpatient hospice. And so she was quite familiar with hospice and all that it could offer in contributing to the really loving care of patients at the end of life. We also became very concerned as a care team that this family was becoming completely overwhelmed by the burdens of caring for these two boys. And yet, we're so overwhelmed that they really couldn't even process all the repeated offers for help. And both the parents were not really in the same place when it came to acknowledging what kind of help they needed. These repeated requests, though, to talk about feeding tolerance and to talk about some of these symptoms that this child was facing created quite a dilemma for the care team because it introduced this element of doubt on the part of us as a team. Once you have that doubt, you begin to erode at some of that trust because it colors how you interpret these reports of symptoms. And we began to wonder whether there was any other reasoning behind bringing forward some of these symptoms. But we also began to wonder about what was this differential understanding of suffering and how much this child was suffering. And was he suffering? So in addition to the AAP statement, I've also provided here for you the ethical religious directives for Catholic healthcare services as well, that speaks about the moral obligations for the use of extraordinary treatment, and also the obligations regarding provision of medical nutrition and hydration, and how it can be discussed and can be appropriate in those patients with persistent vegetative state, but also how one can reasonably discuss the times where it can be withdrawn. We felt as a team that we were not at that place, but I look forward to a really robust discussion as to what this group here thinks about what would contribute to that conversation. Now, in case number 2, this was a case that really opened up a whole new domain in the patient-doctor relationship. So as physicians, and I won't take you through the entire case, but in short, this was a patient with Wolff-Hirschhorn syndrome, which is a genetic condition, and I provided some information to describe a little bit more about the condition and all of its features to you. But among many other features, these children do have significant cognitive impairment. And this particular child, not all patients with Wolff-Hirschhorn, but this particular child was having significant renal impairment as well. And so the discussion was to be had about whether or not this patient was a candidate for renal transplant. Now, because of HIPAA laws, providers are bound and cannot discuss the details of this case outside of that patient-doctor relationship. But parents and patients are not bound by those same restrictions. And so it caused a lot of us to think about what impact does social media have on the patient-doctor relationship? What impact does this have on the trust that we have in that relationship as members? Is this a violation of trust, of this bidirectional trusted relationship, knowing that we are putting one side of the conversation out there for many to see, many to react to, but not the other? One of the downstream repercussions of this case was the experience that providers had and that parents had in caring for patients with this condition long after this case had really reached its final conclusion, because we care for many more patients with Wolff-Hirschhorn syndrome. And also, I would like you to invite you to think about what it was like for the team to continue caring for this patient who continued to receive care at CHOP. And in case number 3, I would like us to be able to have a conversation discussing the challenges in determination of fabricated or induced illness. So how can we know for certain? Is certainty required? Does the mere fact that we are doubting the validity of these symptoms that are being brought forward by this patient undermine that relationship? And what is the parent perspective on that? And how does this contribute to the conflicts that each of the different team members felt in this particular case? And then a discussion of the lack of trust on that relationship going forward, and what this does to other patients. I can say specifically at CHOP, this is a great challenge because we operate in the land of zebras there. We have many patients referred to us who have quite mysterious symptoms, and many of them have actually been told before they came to us that the parents were really just exaggerating the symptoms that their child was having, or because the doctors couldn't understand what was happening, there must have been something wrong with what the parents were doing. And it's not uncommon for us to find really unique and rare diseases that are accounting for these symptoms. What is the impact of that on how we approach these other cases? So I look forward to a really quite robust discussion. Thank you very much.